Welcome. In this session, we'll be discussing about non-proliferative diabetic retinopathy or NPDR and diabetic macular edema or DME. DME belongs to the spectrum of NPDR. We'll be discussing the major clinical trials on DME in the next session and discuss the remaining salient clinical trials in this session. Non-proliferative diabetic retinopathy is defined as progressive intraretinal microangiopathy primarily caused by chronic hyperglycemia. So the changes in non-proliferative diabetic retinopathy is limited to within the retina posterior to the internal limiting membrane. This is in contrast to the changes in proliferative diabetic retinopathy which occur anterior to the internal limiting membrane. And apart from the changes in blood vessels, the parenchymal cells of the retina, namely the neurons and glia, are also said to be affected by diabetes mellitus as evidenced by subtle anatomic and functional changes in the retina of patients with diabetes mellitus but before the appearance of clinically evident diabetic retinopathy. Diabetic macular edema or DME belongs to the spectrum of non-proliferative diabetic retinopathy as we have discussed and is defined as thickening of the retina in the macular area. Microaneurysms are the first visible clinical sign of diabetic retinopathy and is considered the hallmark sign of non-proliferative diabetic retinopathy. Clinically, they appear as deep red dots as seen here in this diagram, 25 to 100 microns in diameter, located within the retina. And smaller and non-perfused microaneurysms may not be clinically detectable. They appear first in the posterior pole and later in the mid-peripheral and peripheral retina with increasing severity of diabetic retinopathy. They may be isolated or may occur in clusters, and they may persist or disappear with time. On fluorescein angiography, microaneurysms appear as intraretinal hyperfluorescent dots in the arteriovenous phase as seen here in this photograph and remain hyperfluorescent throughout the remainder of the study. Microaneurysms may or may not show any leakage on fluorescein angiography and appear more numerous on fluorescein angiography than can be detected clinically. Microaneurysms may also be found in other retinal vascular diseases such as retinal venous obstruction, radiation retinopathy, and also occasionally in normal aged individuals. And the occurrence of microaneurysms only in the absence of other lesions of diabetic retinopathy is compatible with normal vision. Retinal vascular hyperpermeability is one of the characteristic vision-threatening pathologic feature of diabetic retinopathy. And on fluorescein angiography, retinal vascular hyperpermeability may appear as leakage of fluorescein from microaneurysms, which is called focal leakage, leakage of fluorescein from incompetent retinal capillaries in a broad area of fundus, which is called diffuse leakage, or fluorescein leakage from other microvascular abnormalities such as erymas. We'll be discussing these fluorescein leakage patterns later in this session. Retinal vascular hyperpermeability leads to the formation of hard exudates, intraretinal hemorrhages, and macular edema, which we are going to discuss. Hard exudates occur when there is extravascular deposition and incomplete clearance of plasma lipoproteins in the retina, occurring first in outer plexiform layer. They appear as intraretinal yellowish white and sharply demarcated deposits as seen here in this color photograph. They are found most commonly in the posterior pole, usually temporal to the fovea and often at the junction of edematous and non-edematous areas of retina. And they can form succinate rings as seen here in this photograph, encircling an area of significant retinal capillary hyperpermeability such as a cluster of leaking microaneurysms. On fluorescein angiography, hard exudates may appear hypofluorescent due to blockage of choroidal fluorescence, and on OCT, they appear as hyperreflective foci in outer plexiform layer as seen here in this photograph. Hard exudates on OCT are defined as more than 30 microns in size, having reflectivity similar to retinal pigment epithelium Brooks membrane complex with posterior shadowing. Hard exudates can appear and disappear over months to years, and when severe, hard exudates may organize and lead to formation of subretinal fibrosis. Two types of intraretinal hemorrhages are seen in diabetic retinopathy: dot blot hemorrhages and flame-shaped hemorrhages. Dot blot hemorrhages, as seen here in this clinical photograph, are located deeper within the retina in the inner nuclear layer and the outer plexiform layer, and appear typically round or oval and are very well demarcated. Small dot blot hemorrhages are very difficult to distinguish from microaneurysms on ophthalmoscopy, but can be differentiated from microaneurysms easily on fluorescent angiography because the dot blot hemorrhages appear hyperfluorescent, whereas patent microaneurysms appear hyperfluorescent. Flame-shaped intraretinal hemorrhages, as seen here in this color photograph, are located more superficially in the nerve fiber layer, and because of their location in the nerve fiber layer, they appear to have wispy feathery margins, and they are similar in appearance to flame-shaped hemorrhages in hypertensive retinopathy. Intraretinal hemorrhages may appear and disappear over weeks to months and can be found both in the posterior pole and in more peripheral retina. But hemorrhage over disc is not typical of non-proliferative diabetic retinopathy and may suggest neovascularization of the optic disc, as may occur in proliferative diabetic retinopathy or another optic disc disease such as glaucoma or papillophlebitis. We have discussed about papillophlebitis in the section on neuro-ophthalmology. Intraretinal hemorrhages can also be found in many other retinal diseases such as retinal venous obstructions, and it is important to remember that significant asymmetry of density of retinal hemorrhages between two sectors of the fundus may suggest a superimposed process such as retinal venous occlusions, for which diabetes mellitus is also a risk factor. For example, if inferior branch retinal vein occlusion occurs in an eye with pre-existent diabetic retinopathy, retinal hemorrhages will be present in all four quadrants, but the density of hemorrhages will be more in the inferior quadrant of the retina as compared to the remaining three quadrants. And this is an important point to note. On fluorescent angiography, as we have mentioned, intraretinal hemorrhages show transmission hyperfluorescence by blocking choroidal fluorescence. Diabetic macular edema is an important topic by itself, but it belongs to the non-proliferative diabetic retinopathy spectrum and so will be discussed here. Diabetic macular edema is defined as thickening of the retina in the macular area, which can be detected either ophthalmoscopically or on OCT, as seen here in these two photographs. Diabetic macular edema is an important cause of vision loss in diabetic retinopathy, and this is very important to remember. The early treatment of diabetic retinopathy study or ETDRS found that 32% of untreated eyes with DME involving or threatening the foveal center had a decrease in visual acuity by 3 or more lines on the ETDRS chart over 3 years. Visual acuity decline in diabetic macular edema has been correlated with both center point thickness on OCT and area of leakage on fluorescent angiography in a DRCR study. DRCR stands for Diabetic Retinopathy Clinical Research Network, and we'll be discussing about a number of reports from DRCR in this and the next two sessions. Clinically, diabetic macular edema is best detected by stereoscopic examination of the posterior pole on slit lamp with a macular lens, and for this purpose, contact lenses are better than non-contact lenses, but non-contact lenses are more frequently used because they are more convenient to use. And the zone of macular edema appears as an area of decrease in retinal translucency and blurring of underlying RPE and choroidal details because of intercellular separations in the edematous area, resulting in light scattering. And in well-developed cystoid diabetic macular edema, cystic spaces can also be clinically detected. Untreated, diabetic macular edema may persist or resolve spontaneously. Although diabetic macular edema is considered to belong to the spectrum of non-proliferative diabetic retinopathy, diabetic macular edema can be associated with any stage of either non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, and the retinal thickening detected clinically or on OCT can be found either in areas of retinal vascular hyperpermeability as detected on fluorescent angiography or in areas of retinal ischemia also detected on fluorescent angiography. In areas of retinal vascular hyperpermeability, as we have discussed, the leakage of fluorescent can be focal from leaking microaneurysms or diffuse or cystoid from generalized retinal capillary incompetence. These two fluorescent angiograms show early and late phases of focal leakage from microaneurysms, and this angiogram shows diffuse leakage, more specifically the petaloid cystoid pattern of diffuse leakage. We'll see further examples of focal and diffuse leakage later in this session. And in areas of retinal ischemia, retinal thickening can occur from thickening of ischemic retina. Following the advent of OCT and anti-VEGF injections in the management of diabetic macular edema is classified into centered involved diabetic macular edema and non-centered involved diabetic macular edema. Centered involved diabetic macular edema is defined as thickening of the central 1 mm subfield on OCT. This 1 mm diameter circle around the foveal center is called the central subfield, and this is surrounded by 8 more subfields, with the diameter of the middle circle being 3 mm and the diameter of the larger circle being 6 mm. The subfield thickness depicted in each sector does not refer to the retinal thickness at any particular point within that sector, but refers to the average retinal thickness in that sector. It is also important to note this topographic depiction of retinal thickness is based on OCT and not fundus photograph or ophthalmoscopy, and is now universally provided by all OCT platforms. So centered involved diabetic macular edema refers to thickening of the central 1 mm subfield on OCT, and non-centered involved DME refers to thickening of the retina outside the central 1 mm subfield on OCT. Previous characterization of macular edema by ETDRS as clinically significant macular edema or CSME based on ophthalmoscopy and or fundus photography is defined as presence of any one of the following 3 factors. And this characterization of macular edema as CSME was important in the era when focal and or grid laser photocoagulation was the primary treatment for diabetic macular edema, and CSME was the indication for focal and or laser photocoagulation. But this characterization of macular edema as CSME is no longer used after the introduction of OCT and anti-VEGF therapy in the management of diabetic macular edema. And these 3 clinical signs defining CSME include retinal thickening at or within 500 microns of the foveal center, hard exudates at or within 500 microns of the foveal center associated with adjacent retinal thickening, and retinal thickening of at least 1 disc area in size, any portion of which is within 1 disc diameter from the center of the fovea. It is important to remember that currently, the categorization of diabetic macular edema as centered involved or non-centered involved diabetic macular edema based on OCT is considered while deciding management of diabetic macular edema, while categorization of diabetic macular edema as CSME or non-CSME as defined by ETDRS based on ophthalmoscopy and fundus photography is not. OCT is the most common diagnostic imaging modality used for evaluation of diabetic macular edema, and the following features may be detected on OCT singly or in combination, and these include diffuse macular edema, cystoid macular edema, subretinal fluid, and vitreomacular traction. Diffuse macular edema is described as generalized heterogeneous, mildly hyporeflective, spongy appearance of the edematous retina as compared to normal areas of the retina, mainly confined to outer retinal layers such as the outer nuclear and the outer plexiform layers. Cystoid macular edema refers to low reflective intraretinal spaces being present in the retina separated by hyperreflective septa, and typically they are present in the outer plexiform layer. These cystic spaces may occasionally contain hyperreflective material. Subretinal fluid, as seen here in these 2 OCT photographs, can be differentiated from intraretinal fluid by high reflectivity of the posterior layer of the neurosensory retina, and subretinal fluid in diabetic macular edema is said to originate from intraretinal fluid through a breach in the external limiting membrane, and presence of subretinal fluid at baseline has been associated with a better response to anti-VEGF injections. Vitreomacular adhesion in diabetic macular edema can be in the form of vitreomacular traction or epiretinal membrane. These two OCT photographs show vitreomacular traction exerted by the posterior hyaloid either focally or in a diffuse area of the retina, and response to treatment of the various OCT patterns of diabetic macular edema are different, with diffuse retinal thickening demonstrating a greater reduction in retinal thickness and a greater improvement of visual acuity as compared to the other types of diabetic macular edema. Hard exudates are also commonly detected as hyperreflective foci in eyes with diabetic macular edema, as seen here in this OCT. Capillary closure is the other vision-threatening pathologic feature of diabetic retinopathy, and it appears as non-perfused areas on fluorescein angiography in the macula and or the periphery, and as flow deficits in superficial and deep retinal capillary plexuses on octa. Foveal ischemia appears as an enlarged and irregular foveal avascular zone on fluorescein angiogram, as seen here in this fluorescein angiogram. Capillary closure is an important cause of vision loss in diabetic retinopathy, and this is very important to remember. It causes vision loss both by causing macular ischemia and by stimulating neovascularization and its sequelae, which we will be discussing in the session on proliferative diabetic retinopathy. Retinal ischemia is a sign of advanced non-proliferative diabetic retinopathy, and associated features of retinal ischemia, which are found adjacent to areas of capillary non-perfusion, include intraretinal hemorrhages, which we have already discussed, cotton wool spots, changes in major retinal vessels, particularly venous bleeding, and intraretinal microvascular abnormalities or edemas, and we'll be discussing these features next. With extensive capillary closure, retina acquires a featureless appearance with relative lack of clinical findings of diabetic retinopathy. Cotton wool spots, also known as soft exudates or nerve fiber layer infarcts, as seen here in this clinical photograph, occurs due to relative ischemia of the nerve fiber layer, which results in interruption of the exoplasmic flow. Cotton wool spots appear as whitish patches with wispy margins situated in the inner retina and usually appears and disappears over weeks. Fluorescein angiography shows capillary non-perfusion in the area of cotton wool spots. So this area of capillary non-perfusion corresponds to this area of cotton wool spots, which has developed due to ischemia of the nerve fiber layer because of this capillary non-perfusion. Changes in larger retinal vessels include dilated and tortuous venules, venous beading, which are localized areas of alternate constriction and dilatation of venules, as seen here in this clinical photograph, venous loops, as seen here in this clinical photograph, and arteriolar narrowing and whitening in advanced stages of diabetic retinopathy. Intraretinal microvascular abnormalities or edemas are segments of retinal capillaries appearing dilated and tortuous, as seen here in this clinical photograph. In contrast, normal retinal capillaries are not visible on ophthalmoscopy. Edemas are said to provide function of collateral vessels and are often situated at the margin of non-perfused areas in the retina. Unlike extraretinal neovascularization, which occurs in proliferative diabetic retinopathy, edemas do not migrate anterior to the internal limiting membrane and thus can be differentiated from extraretinal neovascularization by stereoscopic examination on ophthalmoscopy and on octa. Edemas do not appear to cross over major retinal vessels, which extraretinal neovascularization may appear to, and edemas do not occur over the optic disc. Edemas appear slightly more dilated than extraretinal neovascularization, and edemas may leak on fluorescein angiography but do not leak as profusely as extraretinal neovascularization. On fluorescein angiography, edemas appear hyperfluorescent in arteriovenous transit phase, as seen here in this photograph, adjacent to areas of capillary non-perfusion, and may leak in later phases but not as profusely as extraretinal neovascularization of proliferative diabetic retinopathy. Featureless retina is occasionally detected in patients with diabetes, and it is characterized by relative absence of clinical features of diabetic retinopathy such as intraretinal hemorrhages, venous changes, and edemas, and this typically occurs in eyes with severe retinal ischemia. This relative absence of clinical features of diabetic retinopathy may mislead diagnosis, and these eyes, because of the underlying severe retinal ischemia, are at high risk of progression to proliferative diabetic retinopathy. but examination does show arteriolar narrowing and thinning and absence of normal vessels, and OCT examination reveals retinal thinning in these cases. Fluorescent angiography in these eyes demonstrates extensive capillary non-perfusion. Epiretinal membranes are more common in diabetic retinopathy eyes, and posterior cortical vitreous is more tightly adherent to the retina in diabetic retinopathy eyes, and this is called dot posterior hyaloid, and traction on the retina from these two entities may contribute to macular thickening. And when macular thickening is predominantly due to vitreomacular adhesion, leakage on fluorescent angiography is diffuse but not prominent. And in diabetic macular edema eyes in which vitreomacular adhesion is detectable on OCT, first non-surgical management of macular edema is attempted prior to deciding whether surgical management is required. On OCT, vitreomacular adhesions can be either diffuse as seen here in this photograph or focal as seen here in this photograph. Diffuse vitreomacular adhesions are also known as thick or taut posterior hyaloid and is characterized by flat appearing foveal contour of the retina on OCT and thickened hyper-reflective linear vitreoretinal interface. Subretinal fibrosis may occur in eyes with diabetic retinopathy and can occur from long-term deposition of very severe hard exudates in the center of the macula or from spread of scarring from a laser photocoagulation scar. And subretinal fibrosis appears as a mound or sheet of yellowish-white deposit beneath the retina at or near the center of the macula. Scars of previous laser therapy can also be found in eyes with diabetic retinopathy, and they appear as focal, circular, either hypo or hyperpigmented scars on ophthalmoscopy. We will be discussing two systems of grading severity of diabetic retinopathy, the ETDRS system and the ICDRS system. The gold standard for photographic grading of severity of diabetic retinopathy used in most clinical trials is the ETDRS Diabetic Retinopathy Severity Scale developed in 1991, and it is based on 7 stereoscopic 30-degree color fundus photos, and the findings in these photos are compared with reference photographs denoting the threshold severity of each lesion type. This diagram shows the 7 photographic fields to be captured in each eye during fundus photography. But the ETDRS DRSS system is complicated for use in routine clinical scenarios, and this chart shows the ETDRS DRSS grading system, and in this column the corresponding ICDRS category is mentioned. We note here that the ETDRS DRSS grading system and the ICDRS grading system do not match exactly, and this is the remaining portion of the ETDRS DRSS grading system. The second grading system is the International Clinical Diabetic Retinopathy and Diabetic Macular Edema Severity Scales, or the ICDR system, which was published in 2003 and is based on dilated ophthalmoscopic examination and had no requirement for color fundus photography or reference images. It closely correlates with the ETDRS DRSS grading system but is much more simple and convenient to use for routine clinical purposes. The ICDR grades diabetic retinopathy as no apparent retinopathy when there are no clinical features of diabetic retinopathy, as mild non-proliferative diabetic retinopathy when only microaneurysms are present, as moderate non-proliferative diabetic retinopathy when clinical features of diabetic retinopathy in addition to microaneurysms are present but do not satisfy the definition of severe non-proliferative diabetic retinopathy, and severe non-proliferative diabetic retinopathy, which is defined as the presence of any one of more than 20 intraretinal hemorrhages in each of 4 retinal quadrants, venous beading in 2 or more quadrants, and edemas in 1 or more quadrants, and this is called the 4-to-1 rule, which is very important to remember. And when 2 or more of these criteria are present, it is described as very severe non-proliferative diabetic retinopathy but is not included in the ICDR disease severity scale. The ICDR categorizes all clinical signs of proliferative diabetic retinopathy as one single category called proliferative diabetic retinopathy, but this classification of diabetic macular edema has been superseded by the OCT-based grading of diabetic macular edema into centered involved and non-centered involved diabetic macular edema. And the importance of grading severity of diabetic retinopathy lies in the fact that In ETDRS clinical trial, risk of conversion of severe NPDR to high-risk PDR was found to be 15% and 60% within 1 and 3 years of diagnosis of severe NPDR. We'll be defining what high-risk PDR is in the session on PDR. The ETDRS clinical trial also found that the risk of conversion of very severe NPDR to high-risk PDR was even greater at 45% within 1 year of diagnosis of very severe NPDR. Clinical evaluation of diabetic retinopathy includes taking a history about ocular complaints, duration of diabetes, very important, associated systemic risk factors such as hyperglycemia, hypertension, hyperlipidemia, anemia, nephropathy, and pregnancy, all of which can contribute to rapid progression of severity of diabetic retinopathy, ocular drug history, particularly previous anti-VEGF therapy, because response to anti-VEGFs may be variable and this may help in deciding on future anti-VEGF, and systemic drug history, particularly about use of thiazolidinediones, which are a class of anti-diabetic drugs but have been found to promote diabetic macular edema. Ocular examination includes recording visual acuity and intraocular pressure, and undilated examination of the anterior segment to detect neovascularization of the iris, along with gonioscopy if there is elevated intraocular pressure and/or iris neovascularization to detect angle neovascularization, and this is a very important but often omitted component of examination of diabetic patients. And finally, a dilated posterior segment examination, and it has been found that without dilatation, presence and severity of retinopathy is correctly diagnosed in only 50% of eyes. Fundus photography is the best method for documenting the severity of diabetic retinopathy, and serial photographs help document the rate of progression of diabetic retinopathy. Fluorescein angiography can characterize diabetic macular edema as either focal edema or diffuse edema. Focal edema on fluorescein angiography occurs from leaking microaneurysms as seen in these mid and late phase angiograms in a patient with leaking microaneurysms, and diffuse or cystoid edema on fluorescein angiography occurs from generalized retinal capillary incompetence and occurs across a broad area of the fundus as seen in these mid and late phases of fluorescein angiogram, and is not restricted to the locations of the microaneurysms. But fluorescein leakage does not necessarily correlate with areas of retinal thickening on optical coherence tomography. And after the advent of optical coherence tomography, the role of fluorescein angiography in diabetic retinopathy is currently limited to detecting macular ischemia as a cause of otherwise unexplained loss of vision as seen here in this photograph, and detecting early extraretinal neovascularization which may be missed clinically, particularly in patients with preretinal and/or vitreous hemorrhage. Wide field fluorescein angiography may be more efficient in detecting neovascularization, and as we have mentioned, Hermes can show leakage similar to extraretinal neovascularization and needs to be differentiated by either stereoscopic examination or by OCTA. So fluorescein angiography is no longer used routinely to detect microaneurysms and retinal capillary hyperpermeability, and is not useful for grading severity of non-proliferative diabetic retinopathy. It is important to note that nephropathy or renal failure is not considered as a contraindication to fluorescein angiography. OCT has become the most commonly used imaging modality in diabetic retinopathy, and OCT is now the gold standard for evaluating retinal thickness, its progression and response to treatment. And OCT is the most commonly used imaging modality to quantitatively assess retinal thickness in diabetic macular edema. OCT gives average retinal thickness data of each of 9 subfields of the macula as shown here in this diagram, and also the total macular volume, and DRCR concluded that the central subfield thickness is a useful metric for assessing the central macular thickness. The central subfield thickness is the average retinal thickness in a circle of 1 mm diameter centered on the foveal center, and CST measurements are more consistent than thickness measurement of the point in the center of the fovea. And the DRCR stated that the increase of central subfield thickness by 11% on time domain OCT is likely to be real. But it is important to remember that CST measurements on spectral domain OCT, which is the current standard technology of OCT, are greater than CST measurements on time domain OCT by 30 to 55 microns in eyes with DME. In addition to monitor the retinal thickness, OCT can also evaluate the vitreoretinal interface, as we have discussed. Several OCT findings have been described as poor prognostic biomarkers following anti-VEGF therapy for diabetic macular edema, and these include disruption of ellipsoid zone being a part of the inner segment of the photoreceptors, disorganization of retinal inner layers, also called DRIL, which is an inability to distinguish between the various layers of the inner retina in the central 1 mm zone, as seen here in this photograph. Hyperreflective retinal foci located in the intraretinal and subretinal spaces, which correspond to subclinical lipid deposits, so there are no clinical correlates to hyperreflective retinal foci on OCT, and in contrast to hard exudates, hyperreflective retinal foci are defined as less than 30 microns in size, of similar reflectivity to nerve fiber layer, and without posterior shadowing. Hyperreflective choroidal foci are similar lesions occurring posterior to the RPE-Brooks membrane complex, and these hyperreflective retinal and hyperreflective choroidal foci are said to be inflammatory biomarkers, and eyes with these lesions have been found to respond better to intravitreal steroid implants. Other poor prognostic biomarkers on OCT include hard exudates in outer retinal layers, whose OCT description we have discussed earlier, cholesterol crystals, also called hyperreflective crystalline deposits, which appear as linear hyperreflective deposits parallel to and on or above the retinal pigment epithelium and do not show any shadowing, and they correlate with bright white yellow shining lesions on ophthalmoscopy, as seen here in this color photograph. Large cysts in the outer nuclear layer with absence of bridging retinal tissue is also considered to be a poor prognostic marker, and other poor prognostic OCT markers include thinning of the retina after resolution of macular edema, decreased choroidal thickness, low choroidal vascular index, which increases the risk of progression to proliferative diabetic retinopathy, and taut posterior hyaloid, which we have described. We have discussed about choroidal vascular index in the session on pachychoroid spectrum. Limitations of OCT in diabetic retinopathy include inability to grade diabetic retinopathy and inability to assess extent and severity of vascular abnormalities, hard exudates, and intraretinal hemorrhages. OCTA can detect capillary non-perfusion, as shown here in this photograph, and the yellow arrowheads in this photograph, venous bleeding, Ermers, as indicated by the white arrowheads in this photograph, extraretinal neovascularization, and some microaneurysms, and OCTA may detect these signs before these signs are clinically detectable. So this is a full thickness segmentation image of optic disc neovascularization, and when segmentation is done anterior to the optic disc, only the extraretinal neovascularization remain visible and the remaining vascular network is no longer imaged. Similarly, this photograph shows extraretinal neovascularization with OCTA segmentation being done anterior to the internal limiting membrane and corresponding to hyperreflectivity anterior to the retina in this OCT-B scan. On OCTA, Ermers, as indicated by the white arrowheads in this photograph, appear as branching, dilated, and looping vessels in the superficial retinal capillary plexus near areas of retinal capillary non-perfusion, and this is said to be because they have a higher blood flow than adjacent patent capillaries. As we have discussed earlier, OCTA may enable us to differentiate Ermers from extraretinal neovascularization by segmenting anterior to the internal limiting membrane, and also with the help of the OCT-B scan with flow overlay, which we have discussed in the session on OCTA. OCTA may not be able to detect 40% of microaneurysms because of slow blood flow velocity through these microaneurysms, and OCTA, as we have mentioned, can also detect flow deficits in superficial and deep retinal capillary plexuses in eyes with diabetic retinopathy. But unlike fluorescent angiography, OCT angiography does not demonstrate leakage, which may actually be an advantage in delineating the fine details of the neovascular complex. DRCR protocol AA found that patients with predominantly peripheral diabetic retinopathy lesions on ultrawide field fluorescent angiography had a higher risk of progression of diabetic retinopathy as compared to patients who do not have predominantly peripheral lesions of diabetic retinopathy. Differential diagnosis of diabetic retinopathy is important and includes hypertensive retinopathy, branch and central retinal venous occlusions, macular telangiectasia, ocular ischemic syndrome, Coats disease, radiation retinopathy, anemia, leukemia, and sickle cell retinopathy. So, apart from leukemia, all the others belong to retinal vascular disease spectrum and will be discussed in subsequent sessions. In addition to ocular treatment, which we will be discussing, systemic metabolic control is an integral part of holistic management of non-proliferative diabetic retinopathy, and this is very important to remember. And this includes control of hyperglycemia, hypertension, and dyslipidemia. For long-term control of hyperglycemia, the target HbA1c level should be 7% as recommended by American Diabetes Association, and an HbA1c target lower than this should be approached cautiously as suggested by increased mortality in the ACCORD study. During initial control of hyperglycemia in patients with poorly controlled diabetes mellitus, rapid normalization of blood glucose level should be avoided because it is known to worsen diabetic retinopathy, and this is particularly severe in pregnant patients. The anti-lipid drugs fenofibrates have been found to be beneficial in patients with diabetic retinopathy. The field study found that in patients receiving fenofibrate, the requirement for laser, either focal or grid or panretinal, was lower as compared to patients receiving placebo, and the ACCORD study found that in patients receiving fenofibrate plus simvastatin had a lower rate of progression of retinopathy and a lower need for laser or vitrectomy as compared to patients receiving simvastatin only. The ETDRS found that aspirin use did not affect the severity of retinopathy or rate of visual loss, and there is no contraindication to using aspirin to prevent cardiovascular events for any level of retinopathy, including proliferative diabetic retinopathy. Ruboxystorin, a protein kinase C inhibitor, has been found to lower incidence of sustained moderate visual loss from DME, but has not been made available for routine clinical use. Treatment of diabetic macular edema is indicated when there is center-involved diabetic macular edema with loss of visual acuity, but when visual acuity is normal, despite the presence of center-involved DME, treatment may be deferred, as was recommended by Protocol V of DRCR, which we will be discussing in the next session. This is because there can be spontaneous resolution of the macular edema, but these patients need to be followed up closely and treatment initiated whenever visual acuity deteriorates. Factors deciding need for treatment also include proximity of exudates and thickening to foveal center, status and course of DME in the fellow eye, and systemic metabolic control. Treatment for DME is also indicated prior to scatter photocoagulation for severe NPDR and PDR and prior to cataract surgery, because both scatter photocoagulation and cataract surgery are known to worsen diabetic macular edema. Intravitreal anti-VEGF injections is currently the first-line therapy for center-involved diabetic macular edema. This is because as compared to focal or grid laser photocoagulation, which was the first-line therapy for diabetic macular edema prior to the advent of anti-VEGF injections, anti-VEGF injections result in superior visual acuity gains, and anti-VEGF drugs approved by FDA for this purpose include ranibizumab, aflibercept, brolucizumab, and faricimab. Off-label bevacizumab injections are also used to treat DME. Off-label meaning that the drug has not yet been approved by FDA for use in this indication. Adverse effects of anti-VEGF injections include endophthalmitis, and a meta-analysis of 8 DRCR trials estimated an incidence of 1 endophthalmitis case for every 2,700 injections. Incidence of endophthalmitis following anti-VEGF injections for diabetic macular edema is said to be higher as compared to the incidence following anti-VEGF injections for other indications such as neovascular AMD. Povidone eye drops are critical for prophylaxis of endophthalmitis, and this is very important to remember. And it has also been found that administration of topical antibiotics prior to and after intravitreal injections are unlikely to reduce the rate of endophthalmitis. Multiple serial injections of anti-VEGF may lead to sustained IOP elevation, and a Cochrane meta-analysis found no increase in the risk of serious systemic adverse events and arteriothromboembolic events in subjects being treated with anti-VEGF injections for DME compared to controls. Other risks of intravitreal injections include cataract, vitreous hemorrhage, and retinal detachment. Issues with anti-VEGF injections include cost of injections and the need for repeated injections. Usually monthly injections are given till complete resolution of fluid or there is no further improvement, and following this either monthly PRN or treat and extend regimen of anti-VEGF injections are continued. If focal or grid laser is planned in a patient receiving anti-VEGF injections for DME, anti-VEGF injections are first initiated and laser is not administered prior to 6 months of initiating anti-VEGF injections. Steroids have immunomodulatory and anti-angiogenic properties which have been found to be beneficial in diabetic macular edema, and fluocinolone acetonide and dexamethasone implants were approved by FDA. Because of cost issues, triamcinolone acetonide injections has also been used off-label for this purpose. But none of the steroids has shown superiority as monotherapy to either anti-VEGF or focal and grid laser, and this is according to protocol I of DRCR, which we will be discussing in the next session. But in the subset of pseudophakic eyes, visual acuity results with triamcinolone had been found to be similar to anti-VEGF monotherapy and superior to focal or grid laser. Also, as compared to anti-VEGF, intravitreal steroids for DME need to be administered less frequently, and indications for intravitreal steroids in DME include presence of contraindications to anti-VEGF and incomplete response to prior anti-VEGF injections. Intravitreal steroid injections are associated with a significantly higher risk of cataract, ocular hypertension, and glaucoma. Focal and grid laser photocoagulation, which was the first-line treatment for diabetic macular edema prior to the introduction of anti-VEGF injections, is based on ophthalmoscopy and fluorescein angiography and not on optical coherence tomography. The ETDRS showed that there was a 50% reduction in moderate visual loss, defined as 15 or more letters decline on ETDRS chart in patients with DME undergoing focal and grid photocoagulation as compared to those in whom laser procedure was deferred over a period of 3 years. And after the introduction of anti-VEGF injections, current indications for focal and grid laser for diabetic macular edema include juxtafoveal and extrafoveal diabetic macular edema, inadequate response to anti-VEGF therapy, cost and follow-up issues which may interrupt regular anti-VEGF injection schedule, and contraindications to anti-VEGF therapy. The DRCR modified the ETDRS protocol for focal and grid laser. This diagram shows a group of leaking microaneurysms and also a zone of diffuse macular edema. The leaking microaneurysms are treated with focal laser and the area of diffuse macular edema is treated with grid laser, and the laser burns are very gentle as compared to the white burns of pre-RP in proliferative diabetic retinopathy. So focal laser is direct treatment of leaking microaneurysm in areas of retinal thickening between 500 microns and 3000 microns of the center of fovea, and microaneurysms nearer to the foveal center between 300 microns and 500 microns of the center of fovea can also be treated if center involving edema is present with inadequate visual acuity results following the initial laser procedure. The spot size for focal laser is 50 microns and the duration of burns is 50 milliseconds to 100 milliseconds, and the intensity is only a mild gray white burn beneath the microaneurysms. In the original ETDRS protocol, the spot size was 50 micron to 100 micron, and the intensity of laser energy was titrated to darkening or whitening of the treated microaneurysms. Grid laser is the treatment of all areas of retinal thickening as shown by this zone in this diagram, with or without retinal ischemia between 500 microns and 3000 microns of the center of fovea, and extending up to 3500 microns from the center of fovea in the temporal quadrant. But no treatment, whether focal or grid, is done within 500 microns of the optic disc. The spot size for grid laser is 50 microns and this was 200 micron in the original ETDRS protocol. The duration of burns is between 50 milliseconds and 100 milliseconds, and the optimal intensity of laser energy is one that achieves only a barely visible light gray burn. The recommended spot separation between two adjacent laser burns is 2 visible burn widths. Focal or grid laser can be repeated as often as 16 weeks till there is resolution of macular edema and all leaking microaneurysms have been adequately treated. As we have discussed, in comparison to anti-VEGF injections, focal and grid laser is insufficient either in restoring visual acuity or completely resolving macular edema, and this is very important to remember. Side effects of focal and grid laser therapy include paracentral scotoma, transient increase in macular edema and or decline in best-corrected visual acuity, laser scar expansion, choroidal neovascularization or subretinal fibrosis, and inadvertent foveal burn. According to ETDRS, good response to focal and grid laser treatment is obtained in patients with focal and well-defined leaking areas, succinate retinopathy, and good capillary perfusion surrounding the foveal avascular zone, and the response to focal and grid laser is poor in patients with diffuse retinal capillary leakage, cystoid macular edema, hard exudates in the center of fovea, and extensive capillary non-perfusion near the foveal avascular zone. DRCR protocol de-evaluated the efficacy of vitrectomy with or without additional procedures in eyes with DME having vitreomacular traction. At 6 months, it found that the median decrease of central subfield thickness was 160 microns and BCVA improved by 10 or more letters in 38% of patients but deteriorated by 10 or more letters in as many as 22% of patients. In the absence of visible vitreomacular traction and or epiretinal membrane, vitrectomy is considered to be of no benefit in diabetic macular edema. Ocular treatment can be indicated for NPDR even in the absence of macular edema. The ETDRS showed that scatter photocoagulation in eyes with severe NPDR reduced the rate of severe visual loss and recommended that scatter photocoagulation should be considered in type 2 DM patients with severe NPDR and poor systemic control and or follow-up issues. And scatter photocoagulation is particularly important before and soon after cataract surgery in eyes with severe NPDR and prior to conception or early in pregnancy in pregnant patients with severe NPDR. DRCR Protocol W evaluated the efficacy of aflibercept injections versus sham in reducing the risk of developing either proliferative diabetic retinopathy or center involving diabetic macular edema with vision loss in eyes with moderate to severe NPDR over 4 years, and it found that 34% of patients in aflibercept group as compared to 57% of patients in the sham group developed proliferative diabetic retinopathy or center involving diabetic macular edema with vision loss, but the study did not recommend routine use of aflibercept for this purpose. The incidence of cataract in diabetics is 2 to 4 times greater as compared to age-matched non-diabetics and may be much higher in younger diabetics. In patients with center-involved DME planning to undergo cataract surgery, preoperative administration of anti-VEGF or steroid is imperative. A retrospective study published in 2022 included 6636 eyes and found that the risk of posterior capsular rupture during cataract surgery increases marginally in patients with diabetic retinopathy as compared to patients without diabetes and diabetic patients without diabetic retinopathy, and the risk of posterior capsular rupture is significantly increased in eyes which have undergone prior intravitreal injections, and this is very important to remember. And it is well known that posterior capsular rupture increases the risk of diabetic macular edema, and this is also a very important point to note. So guidelines for cataract surgery in eyes of patients with diabetes include adequately sized capsular axis to prevent anterior capsular phimosis formation, avoiding silicone IOLs which may fog during and after future vitrectomy, avoiding multifocal IOLs which may interfere with visualization during future vitrectomy and or may lead to poorer visual outcome in diabetic macular edema patients because of contrast sensitivity issues, and long-term follow-up following cataract surgery at regular intervals is imperative in these patients. Initial screening of diabetic patients for diabetic retinopathy should be done immediately after diagnosis of type 2 DM and 5 years after diagnosis of type 1 DM, and this is very important to remember. Following that, if the patient does not have any retinopathy, annual dilated examinations are recommended, and for patients with mild to moderate NPDR without diabetic macular edema, surveillance examination should be every 6 to 12 months. In patients with severe NPDR even without DME, and in patients with DME, surveillance interval should be every 2 to 4 months, and prompt review of any diabetic patients is required if new relevant ocular symptoms arise. Pregnancy is a special consideration for diabetic retinopathy, and initial examinations are recommended before conception and early in first trimester, and follow-up frequency depends on presence and recent changes of diabetic retinopathy. Pregnant patients with severe NPDR or DME should be examined every 1 to 3 months till after delivery. Telemedicine has become an important screening and surveillance tool for patients residing in areas with inadequate healthcare facilities. So we list here the other ocular conditions which can be associated with diabetes mellitus, and these include ocular and periocular infections, dry eye disease, corneal abrasion and decreased corneal sensation, neovascular glaucoma, retinal vascular obstructions, anterior ischemic optic neuropathy, diabetic papillopathy, and cranial nerve palsies. To recap the salient points, non-proliferative diabetic retinopathy consists of intraretinal microvascular changes from chronic hyperglycemia. Mild NPDR is characterized by microaneurysms which appear as deep red dots and are the first and hallmark clinical sign of NPDR. On FA, they appear hyperfluorescent and may or may not leak. Moderate NPDR is characterized by presence of lesions in addition to microaneurysms, which include dot blot and flame-shaped intraretinal hemorrhages which appear hypofluorescent on fluorescent angiography. Hard exudates, which are lipoprotein deposits in the retina, clinically appearing as sharply demarcated yellowish deposits, sometimes in a ring called Sarcinet ring surrounding microaneurysms, and appear on OCT as hyperreflective clumps with shadowing. Cotton wool spots, which are nerve fiber layered infarcts appearing as superficial white lesions with wispy margins, venous beading, and loops. Findings on fluorescent angiography and OCTA in moderate as well as severe NPDR include capillary non-perfusion, and macular ischemia due to capillary non-perfusion is an important cause of loss of vision in diabetic retinopathy. Severe NPDR is defined as presence of any one of intraretinal hemorrhages at least 20 in each of 4 retinal quadrants, venous beading in at least 2 retinal quadrants, or intraretinal microvascular abnormalities or ARMAs in at least 1 retinal quadrant. ARMAs appear clinically as dilated and tortuous intraretinal capillaries which may leak but not profusely on fluorescent angiography. OCTA is helpful in differentiating ARMAs from extraretinal neovascularization. An undilated anterior segment prior to dilated posterior segment examination is very important in diabetic patients to detect iris and angle neovascularization. Differential diagnosis of NPDR include hypertensive retinopathy, retinal venous occlusions, macular telangiectasia, ocular ischemic syndrome, Coats disease, radiation retinopathy, anemia, leukemia, and sickle cell retinopathy. Diabetic macular edema belongs to the spectrum of NPDR and is the most common cause of vision loss in patients with diabetes mellitus. Clinically, it appears as an area of retinal thickening with blurring of details of the retinal pigment epithelium and choroid. Hard exudates are often associated with DME, and cystoid changes in the retina may also be detected clinically in long-standing severe diabetic macular edema. On fluorescent angiography, the leakage pattern in DME can be focal from leaking microaneurysms or diffuse from generalized retinal capillary incompetence. Diffuse leakage may also take up the petaloid pattern of cystoid macular edema. 4 patterns of DME may be observed on OCT: diffuse, cystoid, subretinal fluid, and vitreomacular adhesion. DME is categorized as centered involved and non-centered involved DME on OCT. The central subfield thickness or CST measurement on OCT is useful in monitoring progression and treatment response of DME. previous ETDR's definition of CSME is no longer used for deciding treatment of DME. Systemic control of hyperglycemia, hypertension, and hyperlipidemia forms a very important component of management of diabetic retinopathy. Anti-VEGF injections are currently the first-line therapy for diabetic macular edema. Other treatment options include intravitreal corticosteroids and focal and grid laser photocoagulation. Anti-VEGF injections are indicated in centered involved DME. It should also be considered in patients with non-centered involved DME during cataract surgery and prior to panretinal photocoagulation. Intravitreal steroids are indicated when there is an incomplete response to anti-VEGF therapy and if there is any contraindication to anti-VEGF administration. Focal and grid laser is indicated when there is an incomplete response to anti-VEGF therapy, any contraindication to anti-VEGF injections, logistic difficulty in receiving monthly anti-VEGF injections, and in pregnant patients with DME in whom safety of anti-VEGF injections is not yet established. Panretinal photocoagulation is also indicated in severe and very severe NPDR, particularly prior to and after cataract surgery and in pregnant patients to reduce risk of progression to proliferative diabetic retinopathy. In patients with severe and very severe NPDR who also have associated DME, appropriate treatment for DME should also be instituted simultaneously. Screening and surveillance guidelines for diabetic retinopathy are as follows. Initial screening for diabetic retinopathy should be 5 years after diagnosis of type 1 diabetes mellitus and immediately following diagnosis of type 2 diabetes mellitus. Following initial screening, annual retinal examinations are recommended for diabetes mellitus patients without diabetic retinopathy. Patients with mild to moderate diabetic retinopathy without diabetic macular edema should be evaluated every 6 to 12 months. Patients with severe NPDR or diabetic macular edema should be evaluated every 2 to 4 months. Pregnant diabetes mellitus patients should be evaluated once before conception and once early in first trimester and then followed up closely as required. Thank you for listening.